Hello dear friends, very good evening to all of you. I am Dr. Shivani Jain, your NEET PG educator at Unacademy. I have done my MS Ophthalmology from UCMS, Delhi. And that is the book which I authored, Ophthalmology Notes, that is very useful for our foreign medical graduate students. Now friends, these are the links where you can be connected with me. That is once on my Facebook group with the name of Focus Ophthalmology by Dr. Shivani, and there's a Telegram group again with the same name, Focus Ophthalmology by Dr. Shivani. Now you can use the code SHIVIY for all your 10% off on Plus subscriptions. So am I audible to all of you? All right. Chalo friends, so I would like to brief you about the revision sessions which I have taken at Unacademy at YouTube. So we started the last week, 90th and 20th, we took 2 sessions. Yesterday and today we are having the continued part of those sessions where we will be discussing some important questions that are related to your previous year questions. I have taken the similar topics, but I have just twisted the questions so that you become more familiar to those important topics. Guys, these topics are very, very important. You must be well prepared for such questions. Okay. Now, I would like to tell you something about more batches at Unacademy. So on 22nd Feb, we have started a focus batch that is for our foreign medical graduate students who are targeting this June 2021. So all the courses are structured here, guys. You can have a very interactive session. All the educators will be giving you the best of their knowledge. So you can enroll in those courses soon. Now this is the target next 2022 batch where we are beginning on 1st March, and here evening classes will be taken. So you have country's topmost educators which will be taking your classes. Here again you have depth-wise, in-depth, subject-wise preparation for all those topics required for your PG preparation. Now friends, let us start with our questions. The first question which we are taking today is something on vole keratopathy. So similar question has been there in your exams. They have asked you vortex keratopathy or world-shaped keratopathy is seen in which condition? So can anybody tell me where do you have this vole keratopathy? So exactly, vole keratopathy is also called as vortex keratopathy. Another name of this condition is cornea verticillata. Okay, so this was the question which was there in your exam. Cornea verticillata is seen in which particular condition? So this is nothing but accumulation over the cornea in a broomstick manner. Okay, so most of the time it is the drugs which are accumulated in the epithelium or in the stroma of the cornea. So please remember, the most common of them will be amiodarone. Okay, so you had a question earlier on amiodarone. Amiodarone is one which can cause accumulated in the cornea. Okay, apart from that, here in the question we have chloroquine which can cause toxicity in the cornea and can be deposited over the cornea in a vole-shaped manner. Alright, please remember that. Now guys, there are some more drugs, some more conditions where you can have vortex keratopathy, cornea verticillata, and this can be learned with the help of a mnemonic CAD-FIT. CAD-FIT. Okay, this is a mnemonic which you can use. So C here is chloroquine, A is amiodarone, D is diclofenac. Okay, D is diclofenac. F is your Fabry's disease. I is indomethacin. Okay, I is indomethacin. And T is tamoxifen. T is tamoxifen. Alright, so these are the conditions where you can have similar accumulations where you have cornea verticillata. Please remember, this can be a very important expected question. Okay, so all of them should be remembered. Now this is a picture question also, guys. If you can see on the cornea there is accumulation in a broomstick manner. झाड़ू की तरह लग रहा है कुछ, है ना? So this is called as cornea verticillata. Now let's move on the next question, a clinical case scenario based question with a picture here. So this question says that a newborn is brought to OPD with complaints by mother of watering in both eyes since birth. Okay, so please remember watering since birth. She also described that the baby does not open the eye comfortably, that there is a problem in opening the eye. Now when you examined, you saw that there is a large and a hazy cornea. You also see that eye is also large. So what is your diagnosis? Can anybody answer? What is the diagnosis here? Very, very good, Dr. Ashmi. This is your correct answer. Buphthalmos is the diagnosis. Now, not only by looking at the picture, I want that you should understand what are the presenting complaints by the mother in patients of buphthalmos or a congenital glaucoma. Okay, so what is this triad which you see in congenital glaucoma? The triad is BPL, below poverty line. So this is actually fitting into that BPL very nicely. What is B here? Blepharospasm, isn't it? B is blepharospasm. So the mother says that baby closes the eye, baby doesn't open the eye comfortably. That means he is having problems. He is having a photophobia. Then he closes the eye forcefully. This is your blepharospasm. And what is this? Watering from both eye. This will be your L, lacrimation, watering from both eye. So this is absolutely fitting into that BPL, below poverty line, blepharospasm, photophobia and lacrimation. Okay, even if the picture is not there, you should be able to tell through the problem based question here. So that is a very important clinical scenario based one. Now when you saw, you find cornea is not only large, it is also hazy. Not only the cornea but eye is also enlarged. So this is nothing but the eye of a buphthalmic eye. Alright, so you will also see that patient have a large lens, a flat lens may be even subluxated. There may be Habs striae in the Descemet's membrane of the cornea. You can also have a blue sclera, retina, choroid, everything will be stretched, apart from obviously a high intraocular pressure. Okay, so these can be the findings in a patient of buphthalmos. Good. Now what about keratoglobus? What is keratoglobus? What is keratoglobus, friends? So keratoglobus is that you have a conical cornea not only in the apex, the whole of the cornea is bulging, whole of the cornea. Okay, this is keratoglobus. What is keratoconus? There is a conical cornea on the interior surface. Alright, so please remember these things. These are also very important. Another picture where you see a asymmetric buphthalmos, a unilateral buphthalmos. So this can be a picture question, guys. Okay. Chalo. Now let's move on to the next again problem based question. This is a farmer. So here we have a farmer who is complaining of pain along with watering and redness. So you have pain, watering and redness. Now there is a history of injury with a stick. So it's a very significant history, isn't it? You have a farmer with PVR changes. What is this PVR? Pain, decrease in vision and watering. Apart from that, there is a very specific history of injury with a stick. Now when you saw the slit lamp picture, you found something in the cornea and within the anterior chamber. So what is this picture, guys? What is this? This is your hypopion, isn't it? So you must be having a ulcer with a hypopion, and that history is very much suggestive of a fungal ulcer, isn't it? This typical history is very much suggestive of a fungal ulcer. So find out what is next about the fungal ulcer. Yes, Dr. Rashmi, very, very good. So this should be the correct answer, guys. 5% natamycin, which is the drug of choice, and simultaneously you must send corneal scraping for fungal culture. See what happens, guys, when such a patient comes to you. You have to see the patient clinically. You have to make a clinical diagnosis first, okay? It may be a bacterial ulcer, but here the history and the look of the ulcer is very much suggestive of a fungal ulcer. So what do? You take the scraping before you start the treatment, send it for culture. Now obviously culture would take some time, so you won't be waiting. You will start empirically the patient on a antifungal drug, and here the antifungal drug of choice would be natamycin, isn't it? 5% natamycin will be the drug of choice. And again, when the culture report is back, you just confirm your diagnosis, and if additive anything has to be added, you can do that later on. All right, so this is how you have to approach to such questions. Read the question well, find out the clues, whatever can be given. All right, now here what is given in the first choice? Some antibiotics, because we are not suspecting the bacterial ulcer, we are not happy with the first option. Okay, similar here in option number C, you are giving an antibiotic but with a topical steroid. So we know steroids are absolutely contraindicated here. Now what about intracameral vancomycin to remove the hypopyon? So friends, hypopyon is what? It's actually a pus, है ना? So this pus will be resolved on its own the moment you have, the drug which is acting. The hypopyon will gradually resolve. This is one sign when you say that your ulcer is healing, isn't it? Your edema decreases, the corneal lesion decreases, and your hypopyon is resolving. So it is not required to remove or to aspirate the hypopyon as such. The hypopyon will be subsiding on its own when the patient is responding to your medicine. Okay, so this is something about the fungal ulcer, a very important one. Chalo. So now here we have a young male who is coming to you with headaches. There is an eye strain for last 1 year. On checkup, he can read all the lines on Snellen's chart. Now when you plan to check his refractive error for retinoscopy, which drug would you like to use? So guys, please remember, he is a young man, 20 years old. So which drug would you like to use for checkup of his refractive error? Can anybody answer? So the earlier question which we took was a problem-based question from fungal ulcers. Fungal ulcers are very commonly asked to you. Now here the concept has already been asked to you. They have asked you what are the cycloplegics which you used for checking the refractive error. So here I have created just a problem. So what is the answer? So the better answer would be cyclopentolate drops, not Homatropine. The better would be cyclopentolate. Okay, please remember, Atropine ointment will be used when the child is less than 8 years. Okay, preferably when the child is less than 5 years, right? So this will be the cycloplegic of choice. We never take drops because of the systemic side effects. Because there is more systemic absorption by drops, we do not prefer drops, right? What about Homatropine? So Homatropine and cyclopentolate. Cyclopentolate is a better one. So we try to take cyclopentolate. This one would be a better drug as cycloplegia in younger individuals. Okay. Now, if I change the question to 40 years, so what would you like to use then, guys? If somebody who has headache and eye strain for last 1 year, what would you like to do then? Can you answer me? What would you like to do? I hope you've understood the question. So if the patient is 40 years of age with headaches and eye strain, what is your diagnosis? What would you suspect? Anyone? So I will be suspecting a presbyopia, yes or no? I will be suspecting a presbyopia. A patient who can read all the lines on Snellen's chart, still he is having headache and eye strain, I will be suspecting him to have a presbyopia. Okay, so I would not be taking any cycloplegic agent. I would preferably check his near vision. Am I clear? Yes, Dr. Rashmi, very, very good. So that is what I would like to do when a patient is 40 years of age with the same type of complaint. Is it clear to you? Chalo. So now this is a picture question. Something similar to this was there in your examination 2 years back. So what is this sign and where do you see this sign most frequently? What is this sign? Important picture question. Where do you have such a picture? So first of all, this sign is your lid retraction, isn't it? Your lid is retracted. And lid is retracted, and this sign is called as Dalrymple sign, isn't it? You have extrascleral show. Your sclera is visible, isn't it? So you have a lid retraction, and the most common cause of unilateral and bilateral lid retraction will be a thyroid ophthalmopathy. Okay. So for one eye and for both eye, it will be thyroid ophthalmopathy. So friends, This is not proptosis as such. I would say this is first of all a retraction of the lid. You are able to see the bulging eye, the proptosed eye, first of all because of lid retraction. Okay? First of all, please think about lid retraction of lid. Definitely the most common cause of proptosis also would be thyroid. So for both the things you have to look upon thyroid ophthalmopathy, but here the more prominent thing is retraction of the lid. Alright, this is not lid lagging, Dr. Deshmi. This is not lid lag. Lid lag is when you are looking down and your lid is lagging behind. Lid is not following the eyeball. Lid lag, the von Graffi sign will be different. Okay? Dr. Deshmi, is it clear? Beta, this is not lid lag. This is lid retraction. Chalo, let's move on to the next one. So what is absolute contraindication of evisceration? When evisceration should never be attempted, what is the absolute contraindication? So this is a repeat question, friends. This question has been there in your exams already, where you would never like to do a evisceration. So there are two contraindications of evisceration, friends. First is an intraocular tumor. Another one is sympathetic ophthalmia. Okay. Another one is sympathetic ophthalmia or ophthalmitis. Very good. All of you are correct here. This is intraocular tumor. It's not absolute glaucoma. No. It's intraocular tumor. So whenever you have intraocular tumor and your eye, the vision is not salvageable. You cannot salvage the vision. Okay. Then what to do? You're planning to take out the eye. So it's better you do a enucleation. Okay, evisceration is absolutely contraindicated. So please identify these two picture questions also. In evisceration, we have to remove the cornea. The first thing is that you will be removing the cornea, and later on you will be scooping out the internal contents of the eye. So this is called as evisceration. Now, when you do evisceration, actually you're not sure that the microscopic tumor cells are left. You're not sure that you have completely removed the tumor cells. So rather, when you do a scooping, you stimulate those tumor cells to migrate, to go off. So hence your spread will be more. That is why we say that evisceration is contraindicated. So when you plan to treat the patient, you better remove the whole of the globe, taking the longest possible part of the optic nerve with the globe. Why? Because we want that the stump of the optic nerve, which is there within the body, is free from the tumor cells. Okay, so I would say that the correct answer to this question is intraocular tumor. The rest of the conditions, these are the indications of eviscerations. Okay, so when you have a painful blind eye, any end stage disease of eye which is giving pain or a poor cosmetic appearance, it's better to take the eye off. And what will be that procedure? You call this evisceration. Okay, so these can be your picture questions also, guys. Please remember how evisceration looks like, how enucleation looks like. So there can be another question about evisceration. They can ask you which structures are preserved in the eye, which structures are not taken. So sclera, optic nerve and extraocular muscles are preserved. We do not take out these of eye. Okay, so this is your question regarding enucleation. Now, so what is the most serious complication seen in the other eye after traumatic injury to one eye? So very important question from ophthalmology. You must know everything about a sympathetic ophthalmia. Okay, so this is your correct answer here. Now friends, a penetrating injury to eye which is there to your ciliary body. A penetrating injury to the ciliary body, which is the danger area of the eye, can cause a bilateral severe granulomatous panuveitis. Okay, please remember the term bilateral severe granulomatous panuveitis. So you must have a penetrating injury to ciliary body of one eye. Alright, so sympathetic ophthalmia will be developed in both the eyes. So this eye which was non-injured, this will also develop a pan-uveitis and patient may lose the vision. Okay, so please remember the danger area of the eye would be your ciliary body, and sympathetic ophthalmia is a bilateral granulomatous pan-uveitis. Okay, now how are you going to treat sympathetic ophthalmia? This can be another question. How can you treat? How can you treat? Anyone? How would you like to treat sympathetic ophthalmia? So friends, the treatment will be you must give a lot of steroids and you give lot of immunomodulatory agents also. Okay? You must give steroids and immunomodulatory agents also because you want to suppress the inflammation. You want to suppress the panuveitis. But when you want to do a prophylaxis, so for prophylaxis the best is take the injured eye out. So when I ask you what is the best prophylaxis, what is the best prophylaxis? It is enucleation of the traumatic eye. It is better to take out that traumatic eye. Okay, this will be the best prophylaxis. You can give prophylactic steroids also, but when I ask you the best prophylaxis, it is to take out the damaged eye. Okay, I hope you have understood the words which I am using. The treatment is different. After you develop a sympathetic ophthalmia, there is no role of enucleation. Okay, if you want to do a prophylaxis, you must give lot of steroids and you can take out the damaged traumatic eye. Alright, Dr. Pandya. Now, a question which is again important for your exam. What is economic blindness, friends? How do you define the word economic blindness? Anyone? Okay, so what is your WHO definition of blindness? So this WHO definition of blindness is when you have the best corrected visual acuity less than 3/60. Okay, this is your blindness definition by WHO. But when I ask you economic blindness, guys, the answer is different. Bache, this is answer number B. Option number B is your correct answer. All of you are wrong here. The correct answer has to be B. Economic blindness is a condition when your vision is less than 6/60. Now, why we have produced this term? Why? What is the rationale of this term? Actually, it is not blindness, but such a decrease in vision that you are not able to earn bread and butter for your family. Have you understood? The vision is so poor that you are not working professionally to have a good income source for your family. Alright, so this is called as economic blindness. Please understand, this is not same as WHO definition of blindness. Okay, please remember everyone, there are different terms how you can define blindness, how economic blindness is defined, what is social blindness, what is legal blindness. There are so many things here. Now, when we talk about the WHO definition of blindness, it is not only a best corrected vision less than 3/60, but it is also when your visual field is less than 10 degrees. Apart from that, if the patient is not able to count fingers less than 3 meters, then this is also called as blindness. Okay? So there are three things which I hope you have now understood. It's not only a visual acuity less than 3/60, but a visual field less than 10 degrees. So guys, you know this can happen in advanced optic atrophy, advanced cases of glaucoma. Though you have the normal central vision, but the field is absolutely gone. So you may have a very small field. That is also considered as blindness. Okay, so please remember all those definition of blindness. This can be again a separate question. They can ask you what is not true about the definition of blindness, and there can be 3 criteria. Okay, chalo, let's move on to the next one. So friends, all of them are ptosis surgeries except all of them are ptosis surgeries. What surgery would you not like to do in ptosis? So the correct answer to this question is molar recession. Molar recession. please understand the ptosis can be because of various types. We generally treat the congenital ptosis, or a myogenic ptosis. So there may be mostly a problem of LPS muscle. And your LPS muscle is weak. So when your LPS muscle is weak, you would like to do a LPS resection. The word resection means that you cut short the muscle. Muscle थी, आपने muscle को छोटा कर दिया, and then you reattach. So while you do that, the muscle becomes strengthened. Okay, so this is the first ptosis surgery which is very commonly done. But this does not help when LPS muscle does not have a good action. अगर LPS muscle में कोई action ही नहीं है तो आप उसको काट के छोटा करके strong नहीं कर सकते. If the muscle does not have a fairly good action, there is no use of cutting the muscle short. It will not be strengthened. This will be waste. So when you want to correct that type of ptosis, you have to use a sling. That is fascia lata. You will use this fascia lata as a sling and you will tie it to the eyebrow. So that is called as fascia lata brow suspension surgery. Okay, so this is another kind of surgery. Now what about mullerectomy? So mullerectomy is another name for fascinella servate surgery. Fascinella servate surgery, which we use for ptosis of Horner syndrome. Okay, please remember that is used for ptosis of Horner syndrome patients. Alright, so mullerectomy is also a surgery. But what about molar recession? First of all, what does the word recession means? Recession means you weaken. So would you like to weaken molar muscle? No, not at all. We would like to make that muscle strengthen, stronger. Isn't it? Yes, Dr. Shamsher, you are absolutely right. So mullerectomy, fascinella servate surgery is for Horner syndrome ptosis. Okay, that is another name for fascinella servate surgery. The molar recession surgery is actually not a surgery. ये ऐसे ही मैंने fancy सा नाम रख दिया है. Recession of molar is not done. You are not weakening molar muscle. It is not required for any kind of stuff. Okay, so friends, these were the questions which we have discussed today. So I hope that you have liked the session. Next month again we will be meeting with similar questions, and if you want any kind of special topic which is to be discussed with you on YouTube, you can let me know. The suggestions are invited. So the next month, in the coming up March session, we can have more questions, or if you want some topics, we can discuss topics also. Hanji, please let me know if you want something from my side at Unacademy, at YouTube. We'll be discussing that in the month of March. Okay. Right, so we will be meeting you again in the coming month with similar questions. And thank you very much guys for attending the session. Have a great day, have a great weekend, and thank you very much.